Hello everybody, my name is Bernhard Ludvik. I'm an associate professor of medicine at the University of Vienna. I'm the acting head of the diabetes clinic, and I'm happy to speak on behalf of the Hamdan Journal of Medicine about the topic how to control diabetes. So if you look at this map, what you can see is now this is the worldwide prevalence of type 1 diabetes in year 2000, and you can see some dark red spots. We have a real high prevalence of patients with diabetes, and if you follow up and have the projections in 2030, what you can easily see, there are much more dark red spots on this map. This means we'll have a tremendous increase in type 2 diabetes and type 1 diabetes as well. So we expect to have more than 230 million of patients with diabetes in the year 2030. And if you look at your specific area, this is Middle East, you see a tremendous increase in diabetes. Diabetes is not a harmless disease because diabetes still is the leading cause for blindness in working adults. It's the leading cause of end-stage renal failure, and it's the leading cause for myocardial infarction and stroke. So if you go to a coronary care unit, you can see that 1/3 of the patients will have diabetes and 1/3 will have prediabetes, so impaired glucose tolerance. And what's not on this slide, diabetes poses you to an excess risk of cancer. So what about the costs? Diabetes is not only a catastrophe for those affected, it's also a catastrophe for healthcare costs. What you can see in this slide, that there was a 4% increase in healthcare costs within 4 years of 32%. What you can see is most of the costs are due to inpatient treatment. And if you look specifically at the drugs and insulin, there's only a relatively small amount attributable to the costs of oral agents or insulin. So when we talk about how to control diabetes, we need to know the pathophysiology, and I will focus on type 2 diabetes because type 2 diabetes is much more prevalent. It's about 90% of patients suffer from type 2 diabetes and only 10% of type 1 diabetes. And we have three major players. This is first of all the pancreas, then it's the muscle and the liver. And the pancreas, of course, we have to specifically look at 2 points. First of all, insulin secretion, insulin production, but quite recently we have to focus on glucagon. I'll show you that in a moment. There's no diabetes without beta cell dysfunction. This is very important. But we have, of course, insulin resistance. And insulin resistance is present many, many years before diabetes develops. And it's already there if you have, let's say, the metabolic syndrome. And the third target, the liver, which means an overproduction of hepatic glucose production. And this is, let's say, a triumvirate which is involved in the pathogenesis of type 2 diabetes. And if you have drugs for the treatment of type 2 diabetes, you can focus specifically on one of those organs. So let's turn to the pancreatic islet cells. The pancreatic islet cells constitute of alpha cells, which produce glucagon, beta cells, which produce insulin. What happens is when you ingest carbohydrates, you have an increase in insulin secretion and you have a decrease in glucagon secretion, which is not present with patients with type 2 diabetes. And in between, you have amyloid plaques, which subsequently replace the cells, leading to fibrosis of the islet. So the problem with diabetes is it's a progressive disease. It's not like hypercholesterolemia. When you diagnose hypercholesterolemia, you treat it with a statin and that's it. Diabetes is progressive, and when you diagnose diabetes, probably 50% of beta cell function is already gone. So we are always very late, and there is no real drug to the moment to slow down this decrease in beta cell function. And the most important thing is that when you start treating diabetes, and these are data from the UK PDS, they will show that when you start treating diabetes and try to improve diabetes control very early, this will pay off very late. So this is the actual trial, and after the trial, trying to control diabetes, we could see that an intensive treatment of diabetes could significantly decrease the incidence of diabetic complications. It could not significantly decrease mortality. So after 10 years, we could not say treating diabetes intensively will decrease mortality. But there was a follow-up of this study. And actually, during this follow-up, the patient had been much better controlled than during the actual studies because we had new drugs. But what happened then is after 15 to 20 years, we could see that we had a significant decrease of mortality, which means when you treat diabetes, you have to start treating diabetes and try to have a good control at the very beginning of the disease. So how do we manage hyperglycemia? And I think what we have to consider now is that we have to use a very patient-centered approach, which means, and we know from data that intensive diabetes treatment might lead to hypoglycemia, and hypoglycemia might lead to premature death. So what we need to do is we need to have an optimal control without hypoglycemia. And this is very hard to achieve, but it's more and more achieved easily because we get new drugs. So if somebody, actually you have here more stringent and less stringent treatments. So what you have to do is you have to individualize the treatment, meaning that if somebody is newly diagnosed, has low risk for hypoglycemia, is highly motivated, and has no significant comorbidities, you want to bring his HbA1c as close to normal. If somebody has a long diabetes duration, has a high risk for fatal consequences of hypoglycemia, has, let's say, a short life expectancy or comorbidities, you might be less stringent, which means at this point you will try to get a HbA1c of 6.5, 7%. Here probably you will tolerate an HbA1c of 7, 7.5 or even 8%. So the first and most important means of treatment of type 2 diabetes is non-pharmacological, which is exercise, which is very hard to achieve in patients, and this is medical nutrition therapy. And so first of all, we try to achieve weight loss for overweight and obese people, and most of the patients with diabetes are overweight and obese. Second, there is no clear diet. The only thing what we can say is we need a caloric restriction, we need a decrease in saturated fat, and we need carbohydrates with low glycemic index, which is, for example, whole grain cereals and products. So let's turn to the pharmacological treatment. And we have a lot of targets. We have targets for the carbohydrate absorption. We have target for the insulin production, for hepatic glucose output, and for insulin uptake or insulin sensitivity. First of all, we have the glucosidase inhibitors. They delay the absorption of glucose. They're not very effective, and they have a lot of side effects such as bloating. Then we have the sulfonylureas and glinids, which increase insulin secretion. They do carry the risk of significant hypoglycemia. We have the new agents, the incretin mimetics and DPP-4 inhibitors, which increase, and I will show that in a moment, insulin release, decrease glucagon production. Of course, then we have metformin, a very old drug, but this drug actually forms the first line basis for our medical treatment of diabetes by decreasing gluconeogenesis and increasing hepatic glucose, increasing peripheral glucose uptake. And of course we have the glitazones which act on the muscle and the adipose tissue to increase glucose uptake in those tissues. And of course we have insulin replacement therapy. So this is a chart published by the American Diabetes Association and the European Association for the Study of Diabetes, and what you can see is the basis is always metformin, and then you are free to combine metformin with different drugs, and I will talk about some of the newer drugs and maybe some of those we get in the future. What you can see is you could combine metformin with sulfonylureas, with glitazones, with DPP-4 inhibitors, with GLP-1 receptor agonists, and of course you could combine metformin with insulin from beginning on. So we have to target actually the second line therapy to the patient. And there's one example I will show you. This is a quite new concept. This is glucagon-like peptide 1, GLP-1. And GLP-1 is secreted by the L cells of the jejunum, and it's secreted in response to nutrient stimulus. And what happens then is that, first of all, the GLP-1 is increasing insulin secretion in the pancreas. It's decreasing glucagon secretion, which in turn decreases hepatic glucose production. It's slowing gastric emptying, and it's having some satiety signals. So it's a drug binding to receptor which is in different organs and in the vasculature as well. The problem with GLP-1, which is a peptide, is that it's very rapidly degraded by DPP-4. So what happened is that this is the site of production, and what you can see is only a minority of GLP-1 is reaching peripheral circulation. So you cannot give GLP-1 because it's readily degraded. So what you can do is you have two possibilities to increase GLP-1. One of the possibilities is that you block the DPP-4 enzyme. DPP-4 is degrading GLP-1. So if you block DPP-4, you can increase endogenous GLP-1 by 2 to 4-fold. And this, of course, leads to an increase in insulin secretion and a decrease in glucagon secretion. There are 5 currently approved DPP-4 inhibitors. Most of them, or all of them actually, are on the market. Allogliptin, I think, is licensed only in Japan, but the rest of those drugs is available even in our country and in your country as well. So what happens if you compare, this is a secretagogue, insulin secretagogue, and this is actually a study showing typical DPP-4 inhibitor. This is sitagliptin on top of metformin, and it was compared to sulfonylurea on top of metformin. And what you can see is that regarding the HbA1c, you have an identical success. So the decrease in HbA1c is the same for both drugs. So what's the difference? The difference is that if you give a sulfonylurea, you expect an increase in weight, whereas DPP-4 inhibitors are neutral or might even decrease the weight. But the most important advantage of those DPP-4 inhibitors is that they do not cause hypoglycemia, which means as soon as glucose returns to normal, the action of GLP-1 is shut off. And you can see that there is a very low risk of hypoglycemia. And I think this is an important achievement for this new class of drugs. This is another chart which just shows you that when you compare these DPP-4 inhibitors to other drugs, which is metformin or sulfonylureas, you get consistently a lower incidence, a lower risk of hypoglycemia, even when you compare to metformin. But you can see that you have an 85% decrease in the incidence of hypoglycemia when compared to sulfonylurea. This is another comparison against pioglitazone or against GLP-1 agonists. The other possibility to increase GLP-1 is to give some analog, which is not cleaved by DPP-4. And this is a Gila monster, and the first time there has been in this Gila monster Exenatide being developed. Exenatide is a synthetic version of a salivary protein which has a 50% homology with human GLP-1, and this was first marketed, and it's not inactivated by DPP-4. And what you can see is if you inject, and this has to be injected twice a day, once a day, or once a week actually now. If you inject this, you get 10-fold higher GLP-1 equivalence, which means you have a stronger effect on HbA1c, and you have another effect on weight loss because it's acting on the satiety. So what the problem is that GLP-1 also decreases gastric emptying, which means in some patients you will see nausea. Nausea, which over time, of course, will go away. You can see that over time you get less and less nausea. So this is one important side effect. Recently there was a new technology employed, and this is just the microsphere gelanic, which leads to a continuous release of Exenatide, which means you can inject Exenatide it's called Bydureon, Exenatide once weekly. You can inject it once a week and you will get a nice effect. And I show you that the problem is that you need to wait until you get some steady state, and this is achieved after 6 to 7 weeks. So you have to wait 6 to 7 weeks in order to get the full action, but then you can see you have a very good action by just once weekly administration. And this is a series of studies comparing Exenatide once weekly with different other drugs like Exenatide twice daily, sitagliptin, pioglitazone, or even insulin. And what you can see, there's a consistent effect on the decrease of HbA1c of around up to 2%, and in addition you get a very good effect on weight. This is another substance, another drug. It's the liraglutide. It's called Victoza, and it's applied once a day subcutaneously, 0.6 at the beginning and then 1.2 or 1.8 milligrams. And this has a very great homology with GLP-1. So with Bydureon or Exenatide, you expect the development of antibodies. Here you don't have antibodies. So another set of studies actually showing when you compare this Exenatide once weekly with liraglutide once daily, what you can see quite a little stronger decrease in HbA1c with liraglutide. You can see a little bit greater weight loss than compared with the once weekly drug. But on the other hand, what you could see is that you have a higher incidence or higher prevalence actually of nausea. So the once weekly formulation causes less nausea, less side effects